So Joanna Moncrieff is a senior lecturer at University College London and a consultant psychiatrist. She's known for her controversial work on the nature of psychiatric drug treatment, suggesting that psychiatric drugs, like other psychoactive substances, create rather than reverse abnormal brain states. And she has written on the history and politics of psychiatry and the pharmaceutical industry. She is the co-chairperson of the Critical Psychiatry Network, which has campaigned against the increasing influence of the pharmaceutical industry and the extension of psychiatric coercion. She is the author of The Myth of the Chemical Cure, a straight-talking introduction to psychiatric drugs, and she has a new book coming out soon at the end of the year called The Bitterest Pills, which is a critical history of antipsychotic drugs. Please help me in welcoming Dr. Moncrieff.
Okay, thank you very much, Anwar, for inviting me. It's really a great honour to be here and to be part of this programme, this really inspiring programme which is taking the university out to the wider community, something that I'm going to go back and try and emulate in some way back at home in London. And thank you all for coming and struggling through the snow. I guess you're more used to it than me, but it's quite considerable amount of it out there still. So, right, just let me get the things going, right. So that's the book that most of this talk's going to be based on, although I'm going to give you some updates and bring in some material that I've been looking at for my new book as well. And what I wanted to say, really, this is a global humanities programme. This is going to be a talk that's quite a bit of it is about scientific subjects, but what I hope to show you and to demonstrate through this talk is how important it is to take a step back from what are presented as scientific facts, because only when we examine the social and political forces behind them, behind what is presented as science, do we sometimes realise how what are presented as scientific facts are in fact shaped by social and political factors. And what I think this illustrates is one of the theses of Michel Foucault, the French philosopher, who claimed that knowledge is power and power is knowledge. So knowledge legitimizes powerful groups, and powerful groups are able to establish what is taken for granted as knowledge. And he, in fact, used psychiatric knowledge and psychiatric power to illustrate this thesis. So, first of all, let's just think about the current situation that we live in respect to drugs that are prescribed for mental health problems. So what I'm going to be talking about mainly here are drugs like antidepressants, antipsychotics, benzodiazepine, drugs like Valium, Librium, Xanax, drugs that are called mood stabilizers like lithium and Depakote or valproate. And I got all the data out on prescriptions for these different sorts of classes of drugs recently because I knew that there'd been a massive increase in prescribing of antidepressants. But what I didn't know was whether people had just shifted onto antidepressants from something else or whether there'd been an overall increase. Anyway, it turns out that overall there has been an increase because although prescriptions for hypnotics and anxiolytics, that's drugs like the benzodiazepines, haven't changed very much, the prescriptions of antidepressants and other things have gone up considerably. So that increase hasn't been compensated for by a decrease in anything else. And this increased consumption of these medications has been associated very strongly with a message that what they are doing is rectifying an underlying chemical imbalance. And this is a message that's been promoted particularly by the pharmaceutical industry. I like this picture because it represents the balance. You see the woman in the very balanced position. And these statements taken from the Geodon website are very typical of statements that are made about all sorts of psychiatric medications at the moment. The idea that they balance brain chemicals which are imbalanced in mental disorders of certain types. So what that sort of idea epitomizes is the mainstream view, the mainstream understanding of what psychiatric drugs do, which I've called, in order to try and understand both the mainstream view and how we might think differently about what psychiatric drugs do, I've formulated these different ideas into models. So I've called this mainstream view the disease-centered model of drug action. And this is the idea, as I said, that these drugs are working by correcting an underlying abnormality. And it's an idea that's borrowed from general medicine, where most drugs are also understood to act in that way. So, but it doesn't necessarily mean that the drug is targeting the cause of the disorder. So, for example, insulin in diabetes might be a drug that you think of as working in this way. It's not treating the cause of diabetes, but by replacing the deficient insulin supply, it's helping to normalize, it's helping to rectify the underlying abnormality, helping to normalize the body. So the other way that we can think about what psychiatric drugs might be doing is what I've called the drug-centered model, and I've called it this to emphasize that these drugs are drugs, that is, substances that alter the way that the body functions. And what I'm suggesting in this model is that far from working by normalizing the body, these drugs are working by creating an abnormal or altered state. And because they are a special sort of drug called psychoactive drugs, that is, they work on the brain and therefore they alter feelings, thoughts, emotions, and behavior, the altered states they create interact with the symptoms or problems that we call mental disorders. And sometimes these altered states may be useful in someone who is suffering from a deep depression or an intense psychotic state. But it's not that anything's been normalized, it's that the altered state the drugs create may be preferable to the mental experiences that they're having at the time. So an example of this way of thinking about drugs that's maybe not too controversial is the idea that alcohol is useful for social anxiety disorder, which was something I was taught when I was training, just in case you think that I'm just bringing that in. So the idea was not that alcohol corrected a chemical imbalance or obviously that it replaced an alcohol deficiency. The idea was that the characteristics of alcohol intoxication, which we're all familiar with, include becoming socially less inhibited, which can be useful for someone who is who finds social situations difficult. Another example, which I think helps clarify the difference, is the effect of opiate painkillers, so things like morphine. So morphine and opiates in general have a direct action on pain pathways, on the neurological fibers that conduct pain. They slow down the conduction in those fibers. And to that extent, they have a disease-centered model, disease-centered action. But they also are psychoactive substances that create an altered state that typically is characterized by a state of emotional indifference or emotional detachment. So people who have taken opiates for pain often say that they still have some pain, but they don't care about it as much. And that aspect of their effects is a drug-centered effect. So, what am I pointing at? There we are. So just to recap then, so what this alternative model is suggesting is that psychiatric drugs are psychoactive substances, and this is sometimes forgotten, so this is just why I'm putting this slide up. There is no fundamental difference between them and other psychoactive substances. The ones we're familiar with, of course, are the substances that are used recreationally. The difference might be that most psychiatric drugs produce states that are not particularly pleasant, but that doesn't mean that they're fundamentally different in any way. They still, like all drugs, alter the body, and like all psychoactive drugs, because they work on the brain, they produce altered mental states as well. And like all drugs, they produce tolerance. That is, the effects that they have initially don't necessarily last because the body adapts to their presence, and for the same reasons you get withdrawal symptoms when they're stopped. And like other psychiatric drugs, like other psychoactive substances, the state that they produce means that people are not necessarily very good at judging how they're functioning when they're under the influence of the drug. What someone called Peter Breggin, an American psychiatrist, has called a process of spellbinding. We're familiar with that with alcohol, for example, aren't we? That we're not necessarily very good judges of what we can do when we're intoxicated with alcohol, which is why there are drink driving laws, of course. Okay, so that's just an introduction, really, to different ways of thinking about psychiatric drugs. And now I want to just go into the history of these ways of thinking and show you how we got to the position today where the mainstream view, where most people accept a disease-centered model and have forgotten, really, that psychiatric medications could be understood differently. So at the beginning of the 20th century, most psychiatric treatment took place in asylums, like this typical Victorian asylum outside London. And there was very little emphasis on treatment because basically it was thought that there wasn't very much you could do for people who entered an asylum with insanity, as it probably would have been called at that time. As far as treatment was concerned, it was normally thought of to be non-specific, consisting of fresh air, a healthy environment, putting people to work when they were able to. There was a little bit of experimentation with physical therapies. There was a brief fashion for surgery because there was an idea that maybe madness was caused by chronic infection, so there was a fashion for removing people's teeth and sometimes other parts of them. But there was nothing in widespread use that was actually thought of as a specific treatment. Plenty of drugs were used throughout the first half of the 20th century, mostly sedative drugs like the barbiturates, but from the 1930s, stimulant drugs like amphetamines and benzodrine started to be introduced. And they were generally understood to work according to that implicitly, because there was very little discussion about them, very little interest in them, but implicitly they were understood to work according to that drug-centered model. So stimulants were thought to maybe pep you up a bit if you were a bit depressed, make you look a little bit more sassy. And sedatives like the barbiturates were thought to help you sleep or to relax you if you were highly anxious. But as I said, there was really very little official or academic interest in drugs or in treatment of any sort. But this started to change with the introduction of a series of physical treatment procedures, starting in the 1920s with the introduction of malarial therapy for syphilis. So a lot of people in these asylums at that time would have had chronic neurological syphilis. And there was an idea that if you gave them malaria, the high temperatures that the malaria caused would kill off the organism that caused the syphilis. It was obviously quite a dangerous treatment. And to this day, there's no real consensus as to whether it did any good or not. But it did start to change the atmosphere in psychiatric institutions because the staff there started to feel that there was something that they could do, something properly medical that they could do. From the 1930s onwards, a range of procedures were introduced for people with diagnoses like schizophrenia and manic depression, starting with something called insulin coma therapy in the 30s, which was introduced as a treatment for schizophrenia and consisted of giving people large doses of insulin, putting them into a coma, which lasted several hours, and then giving them an injection of glucose to wake them up out of the coma. Also a very dangerous procedure, as you might expect, with a death rate of about 5 to 10%. And then, of course, there was ECT. This is from Homeland, which I've been enjoying. And ECT, again, was introduced for the treatment of schizophrenia, but gradually it became to be associated more with the treatment of depression and manic depression. Now, the important thing about these two sorts of treatment is that they came to be seen as specific treatments for schizophrenia and manic depression, respectively. Insulin coma therapy was described a few years after it had faded out of use, really, as a decisive step from a purely symptomatic to a curative therapy of the psychoses. No one knew how it worked. There were various speculations, but it was nevertheless felt to work by acting on the underlying problem that was causing the symptoms of schizophrenia. And similarly with ECT, which is obviously still in use, No one knew or knows how it works. There have been various theories through the ages, but nevertheless there was a consensus emerged in the 1950s that somehow it was having a specific effect on the underlying pathology that was causing severe depression or manic depression. So the reason I'm dwelling on this is that in the 1950s, therefore, which was the time when all of the modern sorts of drugs that we now have in use in the mental health services were introduced, psychiatry already thought it had two specific treatments: insulin chemotherapy for schizophrenia and ECT for depression or manic depression. And those were the two conditions that structured psychiatric knowledge and diagnosis for most of the 20th century. So the first modern drug that was introduced is usually thought of as the first of the antipsychotic class of drugs, called chlorpromazine. Here it's known as thorazine, its brand name. It was quickly widely adopted throughout institutions in Europe and here. It was introduced here by SmithKline French with a massive marketing campaign. The CEO of the company went on national television to announce the arrival of this miracle drug that would change the nature of the care of the mentally ill. But this is the two French psychiatrists who first used it in France. But it was first understood to work according to that drug-centered model. It was not seen initially as a specific treatment. It was thought to induce a particularly useful and novel altered state. And so people like Pierre Dennecker particularly and Jean Delay described in detail the characteristics of the altered state that it produced. And so their writings contain a lot of descriptions like this of the sorts of effects these drugs had on the people on the patients that they gave them to. So they particularly picked out the emotional indifference that they seemed to cause and the reduced responsiveness, the reduction in initiative and motivation that people seemed to show, and as they mention here as well, a reduction in mental preoccupation, which was useful if someone was mentally preoccupied with abnormal or distressing experiences. Pierre Dennecker went further, and he suggested that what these drugs were doing was replacing the symptoms that someone had, the psychotic symptoms, in the case of psychosis, with a new disease or a new neurological syndrome. And the new neurological syndrome was something rather like Parkinson's disease. These drugs effectively cause Parkinson's disease if you put them up high enough. And what he was saying is, before you get to the very obvious signs of physical Parkinson's disease, you're getting mild signs of Parkinson's disease, which is slowing up mentally and physically, which is what's useful. That's what we want. That's what we're trying to achieve. And other people went along with that view. It was a widely held view in the 1950s. But over the course of the 1950s and 60s, that view transformed, and these drugs started to be seen as specific treatments for the condition of schizophrenia. So textbooks start to talk about them doing more than tranquilizing, penetrating closer to the site of the mechanism of the disease by 1960. And by the mid-60s, a big clinical trial of these drugs declares that, which finds them more effective than a placebo, than a dummy tablet, declares that they should be regarded as anti-schizophrenic, and we shouldn't think of them as tranquilizers anymore. You can see this transformation if you look at advertisements of the time. So early advertisements emphasize the tranquilizing properties of these drugs. They also emphasize how they can be useful in many different situations. So they were widely marketed for agitated behavior in the elderly. They were widely marketed for childhood behavior problems. There's even one advert that more or less says this drug could be useful for all the family. You know, you need to give it to your children because they're badly behaved, your elderly relatives, and you're going to be so stressed out with all these badly behaved children and relatives that you're going to need some too. By 1970, this is an advert for the same drug as the first advertisement I showed you. By 1970, note, it's being advertised as striking promptly at target symptoms which are described as these disorders of thought, affect, behavior, and perception, i.e. psychotic-type symptoms. And it's being described as an antipsychotic. So it's starting to be portrayed as a specific, as a drug that can target the underlying disorder. There's a very similar process occurs with antidepressants. The first drugs that were thought of as antidepressants were actually similar. They were drugs that were used to treat TB, and they were similar to stimulants. They had similar effects to amphetamines, and the first articles about them make that quite clear. They describe how they could make people psychotic and very agitated and prevent them sleeping. But then they start to be described as antidepressants. They start to be portrayed as specifically attacking mood or depressive symptoms, and they start to be distinguished from stimulants, which by that time were gaining a bad name because they'd started to be used recreationally. So there was a need to distinguish prescribed drugs from them. So what happens basically is over the course of the 1950s and early 60s, there is this fundamental change in understanding of what drugs are doing. So prior to the 1950s, as I said, drugs are mainly understood according to that drug-centered model. As far as anyone bothers to try and classify them, they're just classified into sedatives and stimulants according to the sorts of effects the drugs induce. After the 1950s, they come to be classified and named according to the disease or disorder they're thought to treat. And the important point is that this transformation is not based on a lot of research or a lot of evidence that demonstrates that this is how the drugs worked. It's not even based on any analysis or discussion. It just happens, and when the disease-centered model becomes established, people forget that there was any other way to think about psychiatric medications. And the best way of seeing that is how the psychoactive effects of psychiatric medications have just faded out of the literature entirely. It is almost impossible to find any articles that describe the sort of altered state that you get with drugs like Prozac or Seroquel, the new antipsychotics, or Zyprexa. And almost impossible for me to get anything published on those effects. There is just, this can't be interesting sort of reaction. Okay, so how are we doing for time? So I'm not going to spend a lot of time on this, but in my book I go into quite a lot of detail about the deconstructing the evidence that might support the disease-centered model of drug action. And the most important thing, I think, to realize here is that the majority of evidence on psychiatric drugs and whether they're effective or not consists of placebo-controlled trials, comparisons of the drug with an inert substance. Those comparisons cannot possibly demonstrate that the drug is doing anything to the underlying disorder because, of course, there's going to be a difference. If you give someone something that makes them feel different, both physically and mentally, that's a completely different experience than just taking a sugar tablet or a chalk tablet. So they don't do anything to explain how drugs are working. Of course, the best sort of evidence would be if we had good evidence for what the mechanisms were underlying various mental disorders, and then you could work out from the mechanism how the drug might be acting on it, as is the case in many, not all, but many medical conditions. The trouble is, of course, we don't know this for any medical disorders. There are hypotheses which appear as if they might justify the action of drugs in a disease-centered manner, but they are just hypotheses. In the case of the dopamine hypothesis of schizophrenia, one of the best known of these hypotheses, the hypothesis was first thought of because people observed that one of the main effects of the early antipsychotics like haloperidol was to block dopamine receptors, to reduce dopamine activity. And therefore, because it was already believed that haloperidol was having a disease-specific effect, people therefore concluded, oh, well, if this is what haloperidol is doing, therefore the disease must be the opposite. The disease must be overactivity of dopamine. And that's exactly how the dopamine theory of schizophrenia was first came about. There really isn't any independent evidence for it, and there's even less evidence for the serotonin or monoamine theory of depression, which you've probably heard of. And it's now widely acknowledged by experts that there really is no evidence that there are any serotonin abnormalities in people with depression, even though that idea was so widely promoted in the 90s, particularly when the SSRIs were being marketed. I'll skip over that. The other evidence that might support a disease-centered model of drug action is if drugs that are thought to have disease-specific effects are shown to be convincingly superior to drugs that are not thought to have disease-specific effects. But it actually turns out to be quite difficult to find any evidence of this sort at all. So there are quite a lot of trials of other sedative drugs that shows them to have reasonably similar effects to drugs that are antipsychotics. There are two early studies that compared antipsychotics and barbiturates and did find the antipsychotics to be superior. But remember I said that Jean Delay and Pierre Denneker, who were interested in describing the effects of the early antipsychotics, they were particularly interested in distinguishing them from barbiturates. What they were saying is that these drugs produce a different state from barbiturates, which is more useful because they don't simply send someone to sleep. So the sedative action of antipsychotics and other sedatives is not necessarily equivalent, but in any case, there's quite a lot of evidence that benzodiazepines, well, there's many studies that don't really clearly distinguish antipsychotics from benzodiazepines, lithium or opium even. Lots of studies show that drugs that are not conventionally thought of as antidepressants have effects that are equivalent to antidepressants in trials that compare them to placebo or compare them to other antidepressants. Okay, I'll skip over that. So I'm just briefly going to try and flesh out what it would mean to take a drug-centered approach to the use of psychiatric drugs, and then to have a think about how we've got to the situation we're in. The first thing we need to know is we need to think of these substances as drugs, and we need much, much more information about all the effects that they have both in the short and the long term. And shockingly, we really don't have very good information on this for any class of psychiatric drugs. And then we need to work out whether the effects that the drug produces are useful in any individual's particular situation. Are they useful? Are they sustained if we're thinking of giving the drug long term? And, of course, crucially, do they outweigh the disadvantages that are inherent in taking a substance that alters the way that the body works? And I think that there are some circumstances in which the use of some drugs can be useful. So, for example, these are further comments on the sort of state that antipsychotics produce. Similar to the observations that Delay and Denneker made, people who've taken these drugs describe a feeling of physical and mental stagnance, a feeling of being emotionally suppressed. And although these effects sound very unpleasant, people also describe how these effects can be useful in suppressing intrusive and preoccupying psychotic experiences like delusions and hallucinations. But they're not selective. They're not simply suppressing the psychosis. They're suppressing everything. So I think this quote sums it up really well from someone who was on haloperidol, who said, although they felt very well, she felt as if she had nothing to talk about and couldn't remember what she used to find interesting. But she was very much in contact with reality, and that was, for her, in that situation, an advantage. Pierre Denneker commented that what he felt these drugs did was people just lost interest in their delusions. And that's why they were helpful. So for people with psychosis, I think the effects that antipsychotic drugs induce can be useful if someone's in an acute state. They can help reduce the intensity of psychotic symptoms and reduce behavioral disturbance. But there are many considerations, especially with their long-term use, which may outweigh the benefits that they can bring in that situation. And it's also important to point out that many people recover from psychosis. In fact, most people recover from psychosis anyway without drug treatment, although some people will go on to have further episodes. what about antidepressants? Well, as I said, it's actually very difficult to find any description of the psychoactive effects of antidepressants, but taking descriptions from people who've taken them, they seem to have two sorts of contrasting effects. The modern antidepressants, anyway, the SSRIs and various other more recently marketed antidepressants, they seem to induce a state of lethargy and listlessness and drowsiness, but at the same time seem to make some people at least rather agitated and panicky and tense and irritable. I should say actually that they're much milder psychoactive substances than many of the other drugs that are used and prescribed for mental health problems. So in many people they don't have many effects at all, and the effects that they have are more subtle usually. So the question is, I think, with the treatment of depression, well, can these sorts of effects be useful in someone who is depressed, clinically depressed or moderately or severely or whatever? And I think if we were talking to people honestly, we'd present antidepressants in a very different way from the way that they are currently presented. So the way they are currently presented by many doctors and by drug companies is this idea that they will help to normalize an underlying chemical imbalance, or at the very least there's a hint or an implication that they will normalize whatever's going on that's causing the depression. If we were taking a drug-centered approach, this is what I think we would say to people, okay? This drug affects the way people think and feel, but we don't really know how yet, because we haven't studied it enough. It may dampen down emotions, suppress your libido, we know it does that, may make you feel a bit lethargic and drowsy, and some people it might make them feel a bit agitated. Do you think that would be helpful? That to me is what a drug-centered approach would involve in the case of someone with depression and the use of antidepressants. So, finally, I just want to spend a few minutes thinking about why it is that we've got to this stage where the disease-centered model has become so dominant, and why we've forgotten all this information about what psychiatric medications really are, what sort of effects they induce, what they are like as drugs. And the first thing to consider is the professional interests that have been involved. The drug treatment, this new range of drug treatments that came in the 1950s, came at a lucky time for the psychiatric profession, because it was shortly to come in for a barrage of attack and abuse from what came to be known as the anti-psychiatry movement, which was a very broad-based movement that came from many different intellectual quarters and also had a popular aspect to it. I mean, at its height, professors of biological psychiatry had to have armed protection in the Netherlands, for example, people who were investigating the use of ECT. One of the principal intellectual drivers behind the anti-psychiatry movement was Thomas Szasz, and he wrote this book, The Myth of Mental Illness, which was published in 1960, and then numerous other books afterwards, all of which challenge the legitimacy of the idea that mental disorders are medical illnesses. What he's saying through all his writing is that mental disorders are a different sort of thing from physical illness, fundamentally different sort of thing. And of course, this attack challenged the authority of the psychiatric profession, which is a branch of the medical profession, and called into question the basis of its principal approach to managing madness and distress. There was a lot of criticism from sociology and psychology. This was a famous experiment by Leon Rosenhan, where he sent his students into A&E departments, and they reported to the staff there that they'd been hearing a voice saying thud. And they were all admitted to psychiatric institutions, and they were all given a diagnosis of schizophrenia. And so Rosenhan concluded that psychiatrists could not distinguish between the sane and the insane. And I should also say that once they got into the institutions, they acted completely normally. But their normal behaviour was interpreted as being signs of madness. So one of them, who was making extensive notes about what was going on, was said to be showing compulsive writing activity. So psychiatry was on the defensive, and the response that it took was to reassert the medical nature of mental disorders. And the third version of the Diagnostic and Statistical Manual, which is about to be published in its 5th version recently, soon, the third version moved away from the previous psychoanalytically based understanding and classification of mental disorders and started to classify them, started to compile lists of disorders with seemingly objective criteria for identifying them. So it presented mental health problems as if they were as easy and straightforward and non-subjective as if you were identifying a boil or a tumour. And the presumed disease-specific nature of the effects of psychiatric drugs was one of the main pieces of evidence that was mustered to support this approach to psychiatric classification. Because if diagnosis didn't direct treatment, then there really wasn't any point to it. So Robert Spitzer, who was the principal person, the head of the committee that came up with DSM-3, in his response to the Rosenhan experiment, actually emphasized that psychiatric diagnosis was legitimate and important because you could show that drugs and different sorts of treatments had effects in particular diagnostic groups, even though, if you read the book, and as I've tried to show very briefly, that evidence isn't really there. Drugs were also useful at this time because one of the main ways in which psychiatric practice differs from medical practice is in the use of force. Of course, a lot of psychiatric treatment is done without the consent of the patient under the Mental Health Act, or I'm not sure whether you call it the same thing here. I expect so. But in extreme conditions where someone becomes disturbed and violent and has to be held down and injected with something to sedate them, it's quite difficult to pretend that that's a therapeutic treatment activity. Antipsychotics, when they came in, it was soon realized that they were very useful treatments in this situation, that they could rapidly restrain someone and calm them down both physically and mentally, or slow them down both physically and mentally. But because there was already this idea that they were a specific treatment for schizophrenia, they could nevertheless they nevertheless helped these sorts of situations to be portrayed as a therapeutic activity rather than an activity of social control. And Thomas Saz, again, pointed this out. He was one of the first people to refer to these drugs as chemical straitjackets, and he talked about the dangers of seeing drug treatment in this way, that once you start to see what is actually essentially a situation of the forcible control and modification of someone else's behavior, as soon as you start to see this as treatment, you forget the responsibilities and the guilt that you should feel in a situation like that. The other interest group that's obviously been influential in promoting this view of psychiatric drug treatment is the pharmaceutical industry, although interestingly in the 1950s and 60s, up to the 1980s, really, the pharmaceutical industry were also could play both games. They could promote psychiatric drugs as disease-specific or as psychoactive substances, and they were quite happy to do both. But then there was, and they were involved in the early days of creating the modern idea of depression, along with the antidepressants in the 1960s. But then, in the 1980s, there was a crisis over the widespread use of benzodiazepines, and the idea of using mind-altering substances to shut people up, keep people quiet, stop people complaining, got a very bad reputation, rightly, of course. And so, as David Healy's very cleverly shown, they started to change the market for the benzodiazepines into a market for antidepressants. And they needed to get away from that bad reputation. They needed to portray the antidepressants as something that were reversing an underlying disease. So that disease-centered model became very important to them in the early 1990s. And then more recently, of course, we've seen the creation of other conditions, or the changing nature of other conditions like bipolar disorder, to sell new drugs. So this is what I was saying about antidepressants. So the idea that there was an underlying deficiency or disease was sold in a package with the drugs. They very much came together, the idea that you had a chemical imbalance and therefore you needed an antidepressant in the 1990s with the marketing of the SSRIs like Prozac. And Eli Lilly were one of the funders of a big campaign in the UK, and I know there have been campaigns here and campaigns in Australia that are similar, campaigns designed to increase the use of antidepressants by increasing the number of people who are diagnosed with depression. So this campaign suggested that 5% of the general population had depression, 10% of people attending general practitioners. It emphasized that antidepressants are not addictive, which has transpired as completely wrong and is now accepted as completely wrong. And it emphasized that they should be given for a few months and not just used for a brief period. It was very successful. We've already seen how much the prescribing of antidepressants has increased. More worrying, in a way, is the increase in prescribing of antipsychotic drugs, which has happened recently. And this has been achieved in various different ways, by expanding the boundaries of psychosis or schizophrenia, by this new concept of bipolar disorder, which has been heavily marketed, and also by a lot of unlicensed use of these drugs for people diagnosed with anxiety and depression, and in people with dementia, which you've probably heard about. So in a survey in 2007, it was found that 2/3 of people taking the new atypical antipsychotics did not have a diagnosis of psychosis or schizophrenia. Again, the marketing of these drugs has been strongly linked to this idea. I think this is a useful statement for understanding why this idea is so useful to the pharmaceutical industry. Antipsychotic medicines are believed to work by balancing the chemicals found naturally in the brain. That's my emphasis. So as you can see, instead of talking about how these are drugs that alter the way the body works, they're emphasizing all they're doing is just putting right what's there anyway. I don't know if there's anyone here from this program, but this is the early intervention program from Portland, from here in Maine, which is one of these programs that is trying to identify people at early stages of psychosis while they've still got very non-specific symptoms, such as spending more time alone, avoiding friends and family, dropping grades, having trouble focusing or paying attention, losing abilities in athletics or hobbies, okay? Things that many, many adolescents are going to experience. And this sort of program has led, as David Castle, an Australian psychiatrist, has shown, to very much a very large increase in the identification of psychosis or schizophrenia, probably accompanied by this increase in the use of antipsychotics. So the WHO estimate was 14 cases per 100,000. In an English early intervention service, they're identifying 50, and in the Australian service, which has been one of the forerunners in this area, he estimated they were identifying about 100 people per 100,000 population. The advertising and promotion has been very emotive, and a lot of it has been justified by this idea that psychotic symptoms are toxic to the brain. So they have to be stopped at the earliest point possible. You need to prescribe as early as possible. It turns out that it's probably the antipsychotics that are toxic to the brain, that all the evidence that people saw that the brains of people with schizophrenia and psychosis were getting slightly smaller over the first few months of their treatment, it looks as if that's attributable to their drug treatment rather than the disorder. So in particular, I've got a macaque monkey up here because the middle line refers to a study. Well, sorry, I should say first, Jeffrey Lieberman, who's a psychiatrist based in America, conducted a trial which was sponsored by Eli Lilly, which compared haloperidol and olanzapine and brain scanned people for a year, followed them up for a year, and found that within 12 weeks there was evidence of shrinkage in people taking haloperidol. And over a year, there was evidence of the same shrinkage in people on olanzapine as well, but to a slightly lesser degree. They concluded that what this showed was that olanzapine prevented the underlying brain shrinkage better than haloperidol. And they were obviously convinced about this conclusion because Eli Lilly then funded this study with macaque monkeys, which did the same thing, compared haloperidol, olanzapine, and monkeys that were treated without any drugs, and showed conclusively that the brains of these monkeys were smaller in the monkeys treated with olanzapine and haloperidol than the monkeys treated without the drugs. They were given some placebo injections instead. And then there's been a long-term follow-up study done here as well, which also suggests that there was a strong correlation between the shrinkage of the brain and the amount of antipsychotics that people were prescribed. Bipolar disorder has been, as I mentioned, has been another diagnosis which has been promoted by the pharmaceutical industry. And what they've been doing is trying to persuade people. The makers of antipsychotics, and the antipsychotics are the big blockbusters at the moment, the new antipsychotics like Zyprexa and Seroquel, they've been trying to get into the depression market because they know that there's many more people, out there with depression than with psychosis. And the way that they've been doing this, in part anyway, is through this diagnosis of bipolar disorder. So a lot of their advertisements have been about trying to persuade people who might view themselves as being depressed that actually they've got bipolar and therefore they need an antipsychotic. And at its extreme, this trend started to label children with what was called pediatric bipolar disorder. Going back a couple of decades, it wasn't believed that children could have bipolar disorder. It was thought to be something that only started later in life. But then there was this idea that pediatric bipolar disorder can be manifested in different ways from adult bipolar disorder. And this group at Harvard started to do trials with children, some preschool children, testing them with antipsychotics, diagnosing them with bipolar disorder. It turned out they were receiving enormous amounts of money from the pharmaceutical industry, which they hadn't declared. So just a few final comments. To take a step back again, I think it's useful to look at how this increase in the consumption of medications for mental health problems parallels general trends in the increase in consumption over the last half century, much of which recently has, of course, been fueled by debt-fueled consumption. And this debt-fueled consumption has led to rising rates of inequality, particularly the very rich getting even richer. And psychiatric drugs, I think, are an important part of this picture because they are a commodity that encourages people to identify, to see the source of their anxieties and difficulties within themselves rather than out there in society. They stop people asking too many questions that might be awkward politically. They also, as I suggested earlier, help to legitimize the control and containment of people who do not make very good and compliant consumers, people who fall foul of this system. So there's been, in England, a large increase in the use of the Mental Health Act, the forcible admission to hospital of people, but also the use of community treatment orders, whereby people are forced to take treatment in the community. And this parallels, of course, the massive increase in the prison population, both here and in England and Wales as well. So just coming back to the different models of drug treatment for a minute, I'm trying to suggest that there's a better way of thinking about what drugs might be doing when we use them for mental health problems, that we need to acknowledge that they're drugs, that they're psychoactive substances, and we need to understand those effects more. And when we do that, we can use them in a rational and more collaborative way, and a more cautious way. Because the point about the disease-centered model that I think is so dangerous is that it assumes that drug treatment is going to be beneficial. Because, of course, if there's an underlying problem and the drugs are helping to normalize it, well, of course it's a good idea to take them. Why wouldn't you? The drug-centered model, on the other hand, by emphasizing that these substances are drugs, assumes that they might be harmful, and therefore you have to make a good case for using them. And I think I hope that I've shown you that I think it's only when we stand back from this literature that you're able to realize how we've got to this situation where we have a potentially dangerous and completely unfounded model of the way that psychiatric drugs work. That model has become the standard accepted way of understanding these substances and the basis on which they are used. It's only when we stand back and we start to look at the social and political factors that have been involved that we start to appreciate how badly deluded we have all been. Okay, thank you very much. I'll leave it there for now.
Thank you. I know a lot of people have questions, so raise your hand and you'll be given a microphone. We also have 19 people watching us online, including one person in Colombia, in the nation of Colombia. So you're welcome to send a question via email, too, if you're watching us.
Thank you so much for such a amazing and inspiring. I've been waiting years to hear you speak because I've been so concerned about this for years. Particularly, I'm an occupational therapist who's worked mostly a lot in the mental health field, and I see the effects of those antipsychotic medications, the apathy, the disinterest, the social withdrawal, and then I'm supposed to come and help people be motivated to engage in meaningful occupation when they're, in a chemical straitjacket. It's been enormously frustrating for me. A question I have is about this study that was done with the macaque monkeys, where they compared, haloperidol, olanzapine, and a placebo, and it was funded by who?
Eli Lilly.
What did they think about the brain damage associated with their precious drugs?
I don't know that they've made any comment, and they've not altered their information on the Zyprexa website, but to their credit, it was published. So at least they didn't try and stifle it.
And then it was repeated again. And it wasn't funded when it was repeated by Ho et al. In 2011. Do you know?
I think that was a National Institute of Mental Health funded study, and that wasn't an animal study. That was a study following patients.
Okay. Thank you very much.
Thank you for your contribution.
Wonderful talk. I just wanted to get your take on, I've heard chemical imbalance like my entire career, trained on that. What's your take neurologically, like this chemical imbalance? Because I have a lot of speculation on it.
Sorry, what's your question? What exactly?
What's your take on chemical? Sorry, yeah, no worries. What's your take on when somebody approaches you and says, well, this patient has a chemical imbalance, so therefore we need some type of psychotropic intervention?
I mean, my take is that there is just absolutely no evidence that anyone with any mental disorder has a chemical imbalance of any sort.
Right, that's precisely what I was hoping to hear.
Absolutely none. And that we should not be considering treatment on that basis. There are other reasons why we might want to use drug treatment, but we should not be justifying it on that basis. And if we're telling that to our patients, we're being dishonest, I believe.
Good evening. I'm Gail Brazum, the Dean of the College of Pharmacy. I guess I have to take exception to a couple of the statements you say. I do believe that we do have enough evidence in current literature to suggest there is a basis for the disease-centered model, particularly for some drugs that are psychiatric drugs. I would respectfully disagree that I think you've chosen studies that aren't more contemporary studies, and with now us having various models and having various targets for drug therapy, that we are demonstrating that some of these newer psychiatric drugs. The drugs I think you've talked about are the older generations of drugs, and we know that there are problems with those.
Do you want to give me some examples of what
I think some of the new antipsychotics, some of the new, we've got, and I don't have enough top of my head those, but there's literature to suggest that these are done in peer-reviewed studies that aren't drug-funded, that are effective, and I think this disease-centered model assumes that in any drug, a drug in the United States to be marketed has to be, there as a drug, is generally regarded as safe, and there are side effects. And that's why they're prescription drugs. And that's why we have pharmacists and physicians and nurses working in a team to help patients. So I don't think we should completely throw out the disease-centered model, particularly as we understand more and more about genomics and genetics and differences that they have in patients. I can see your point of certainly concern about some other drugs here, but I think you're misleading folks if you think that there isn't a basis from disease for some of the psychiatric.
Well, I would love someone to put the evidence to me for the disease-centered model, and I've been trying to debate with various biological psychiatrists for a long time, and the only one that has debated with me is Ian Reid, I think he's called, from Aberdeen. And he couldn't come up with anything that convinces me that there's any evidence that that any drugs have disease-centered effects. I mean, the evidence about the atypical antipsychotics, the theory is that they're working on dopamine receptors, possibly on 5-HT receptors in combination with some of them. Some of them, that was an idea around in the 90s, seems to have faded a bit. And as I say, there really isn't any evidence that there's any abnormality in dopamine in schizophrenia. You know, there are millions of studies, and some of those studies are going to maybe come up with some evidence that, you know, one or two might come up with some abnormalities in some 5-HT receptor here or there, but overall there's no consensus that there's any abnormality in that system either. Where I think you make good points, and it's important, is yes, we do know quite a lot about the adverse effects of these drugs, and I agree with you that pharmacists and other people are very useful, and it's extremely important that we discuss that information with patients. And some of those effects have been considered by regulatory agencies. So, for example, the FDA, the makers of Seroquel, can't remember who they are from a minute, the makers of Seroquel applied for a license for the treatment of depression for Seroquel, and the FDA decided that the adverse effects of Seroquel outweighed any possible advantage there would be. So they didn't grant them that license, not for the primary treatment of depression anyway. So yes, there are some safeguards, but they did allow Seroquel to be prescribed as a treatment if other treatments have failed in depression or first-line treatments have failed. So they still opened up potentially big market, but yes, there is some. Genomics, I think, is very interesting and important. You know, people respond differently to drugs. And partly what I'm making a plea for is that we do more research and understand better what drugs are doing to individuals, and part of that is understanding how people's genetics influence how they metabolize things, therefore how they experience things, what different effects they might have.
I think where you're going to see the differences is where it's not necessarily how the individuals are going to handle the drugs. It's going to be as we understand the disease-type drugs. A particular patient's going to have a genetic form. Now, it's going to have to be very specific types of genes, and I think we're starting to do that as we are able to do that, as we're able to map the areas of the brain. I think that's where and so I think our disease center model we can't throw out, because we are probably going to treat patients as a function of their type of disease. We're already doing that in different cancers. I think the brain and those are only a matter. If this is a decade of the brain, I suspect that we're going to see tremendous advantages and that we are going to be able to treat the disease, realizing that drugs always will have adverse effects. And we're trying to optimize the beneficial effects with the adverse effects.
So there's a fact that we do something, and then there's a rationale for why we do something. I really appreciate what
Can you speak up?
Yeah. So there's a fact that we do something, and then there's a rationale that we do something. And I think what you spoke to about today is really the rationale for why we prescribe certain drugs for certain conditions. Can you speak to the fact that we do this, regardless of what the rationale is? If we take up the let's say we switch our model to the model that you propose, is the fact that we prescribe these drugs going to be any different based on this change in rationale?
Yeah, no, you're right. Very good point. And for example, benzodiazepines, which in what I'm suggesting are considered to be anxiolytics, to be specific treatments for anxiety, are used widely in all sorts of situations, including in people with psychosis or any sort of disturbance in institutions widely. And in that situation, they're understood to be working according to a drug-centered model. I mean, they're sedatives and restraints. So there are lots of circumstances when people are using things openly, you know, not necessarily interpreting it as treating a disease. The facts, I think, are different with different situations. So the reason that drugs are used for people in institutions, for people who are very disturbed, is because it's very difficult to look after people in that situation, because people are very distressed in that situation, because various drugs can help to dampen and suppress symptoms and therefore help people to improve and help people to be more manageable. In someone with depression, what is the fact of the matter? I was at a meeting of general practitioners recently where it was a meeting about dependence on prescribed medication, such as benzodiazepines and SSRIs. And the reaction of general practitioners is, why are you giving us such a hard time? At least we're not prescribing barbiturates anymore, which were highly toxic. We've got to have something to give to people. So, you know, I think the fact is, when we're treating depression, very often we're treating a perceived need for some sort of quick chemical fix. Or we might be responding to our own sort of distress or helplessness in that situation. So I think it depends on the situation as to what the fact of the matter is, but I think you're right, yeah.
One of the effects or the consequences of what you're talking about seems to me, in a way, is the potential for a more collaborative or more honest conversation. I mean, I spent the first 6 years of my career working in a private psychiatric hospital, and so I feel like I sort of saw everything in one way or another. They used to line up 15 to 30 people for ECT every Wednesday afternoon. But one of the, if we're not sort of suggesting that there are specific, that we're creating a new balance in the body, but instead simply describing, here are the potential benefits and here are the potential consequences, the patient has the opportunity to make a more informed choice. And I've certainly known plenty of people who were very much helped in terms of bringing some sense of order to their lives from a medication, even though they would also say it's terrible to feel small, it's terrible to feel impotent, it's terrible to feel so tired, but it's also nice to not be completely out of control and, so.
Yeah, yes, absolutely. I think you made the point really well. I think it enables a more collaborative discussion about what drugs might and might not be able to achieve. So, they're not going to make everything right. They're not going to necessarily make you feel great. But they may be able to do this. They may be able to just calm you down enough that you can put your life in order a little bit, as you say. So as I said, I think, the basis is describing and having lots of information about what sort of effects drugs might be able to have. But as well as, we do also need to think also about the consequences, about the fact that once people get on drugs, it's difficult to get off them. They often end up on them long term. Then if they want to come off, they might have difficulties. there are all sorts of considerations to be addressed in that conversation. But I agree, it should be a conversation and not as it is at the moment. You see, I mean, I know what many of my colleagues would say to me. Well, of course we do have conversations with patients, but the implicit structuring of that conversation at the moment is, you have an illness, I've diagnosed your illness, and this is the treatment for that illness. You can choose not to take it, as long as you're not under the Mental Health Act, but that's the situation. Whereas, as you point out, it's a very different sort of structured conversation if you take a drug-centered approach.
I just had another comment from sitting in the back of the room. There are 23 psychiatrists in this institution. And in the morning, we'd have the morning report, and we'd hear about the new admissions from the day before. And over time, I became aware that I could predict the diagnosis based not on the symptoms that were described, but on the personality of the psychiatrist who had admitted the patient. And I mean, with great accuracy.
You mentioned that it was with, or you appreciated that Eli Lilly, I think it was, published that study, even though that it showed things that didn't look so great. My concern is that there's a lot of research that happens that doesn't get published. Is there any way to get access to some of this research that shows maybe the drugs aren't as beneficial as they get purported to be?
That's a really good point. There's a psychiatrist and journalist in the UK called Ben Goldacre who's campaigning to try and get trials published, because not only information on adverse effects, but information on efficacy could be suppressed. So if you do a number of trials, one of them comes out positive, 3 come out negative, you just publish the positive one. That has happened a lot, we know that. So there's a campaign to get trial results published, but there's still plenty of other research that might not be published. There's an example is one of, there's been a study, there've been a number of studies of trying to prevent the onset of psychosis in people with these non-specific early signs by treating them with antipsychotics, started off by this group in Australia that I mentioned. One of those studies has happened in Germany, and they published some preliminary findings in 2007 and haven't published anything since. It must be negative, I would assume, because it's such a big area at the moment. It would have been big news if they'd wanted to publish it. So we know that we know that stuff isn't being published.
Hi, I'm proud to say I'm a psychiatrist. I hope I'm not drawn and quartered as I leave the room later. Could you clarify a statement you made about, I think you kind of said all of these medications are addictive, psychotropic medications, and my read on it is the benzodiazepines are, the barbiturates are, but I don't know of literature that suggests the SSRIs are, or the atypical or typical antipsychotics.
Well, it depends how you define addictive. That's the answer. I mean, all these drugs have a withdrawal syndrome when you stop them. There are effects, noticeable effects when you stop them. So if you stop an antipsychotic, you get insomnia and agitation and vomiting. If you stop an SSRI, there's a very prominent withdrawal syndrome. There have been large campaigns by service users in the United Kingdom, by people who've experienced these withdrawal symptoms, to get them recognised. So if you define dependence or addiction as the body becoming tolerant to something and then noticing when it's withdrawn, which it seems to me is the purest, clearest way of defining that, they are all addictive. They're not all nice. People don't crave or don't go and seek SSRIs and antipsychotics in the same way that people do seek out some people do seek out benzodiazepines and barbiturates. So that's the difference. It is the quality of the altered state and the fact that for those drugs it's nice and people go seeking them. But it seems to me that's not a necessary part of how we define addiction or dependence. The actual physical bit is the body getting used to a substance, and that applies with everything.
I think some other clinicians would take issue with that.
Oh, yeah, there's a debate. There's certainly a debate about the nature of addiction and the meaning of addiction.
Yeah, that I would, my own clinical practice, I'd say not everyone that I've seen, most people I've seen abruptly stopping a antipsychotic goes into a withdrawal, and the same with the SSRIs. Some do, some don't. Prozac, fluoxetine, which is a very long half-life, it'd be very rare that someone would have a discontinuation syndrome. Then Paxil, on the other hand, very common. So.
Yes, yes. But I mean, that's the same for everything, isn't it? You know, I mean, that to me shows that they are addictive in the same way, that the ones with a short half-life, you get a withdrawal syndrome with it. Clozapine, you get obvious withdrawal symptoms. Longer-acting drugs, you don't.
Hi. At what point do you think that we should accept responsibility in us, like as individuals? I mean, you go to the doctor, they give you all these sort of treatments that you can take. They try to explain it to you. And I agree that sometimes pharmaceutical ads may be misleading, but the risks and what this drug does and the side effects, they're always at the bottom. They may be little, but they're still listed. So don't you think us as individuals, we need to start showing some sort of responsibility when taking these drugs? And if we feel that it may not be the best treatment, then maybe seek other medical advice, or maybe continue talking to your doctor, because as you said, a lot of these disorders can be treated without the use of drugs.
Yes, I think that's a really good point. People have always sought out chemical fixes. I was reading a book by Elizabeth Gaskell, who was a contemporary of Dickens recently, and the father in that, who's a working-class factory hand in Manchester, is addicted to opium. And it's made quite clear in that book that, you know, this is what gets him through the day in a miserable and very difficult and exploitative environment. So people have always turned to drugs to block things out and blank things out, and people have always looked for a quick fix as well throughout history. So that is one of the reasons why we have as much prescription drug use as we do. And to that extent, people need to take responsibility for it and look for alternatives. But I think there are a lot of people, for example, that go to the doctor undecided because they're not quite sure where else to go. And if the doctor was able to say to them, you don't have to take this, or, you know, said there are alternatives, that, you know, some people would take antidepressants in your situation, but there are these other things to try. If that was said more often, I think that fewer people would take up the option. I do think that the saturation of our society with this message that depression, distress, however you wanted to call it, is a medical disorder, is a chemical imbalance and needs drugs to be rectified, does influence people.
We have a question from the Bideford campus, from Glenn Stevenson of the psychology department. Thank you for the talk. I generally agree with many of your premises and conclusions. What are your thoughts on recent evidence indicating prefrontal cortex alterations in first episode schizophrenics, primarily gamma band oscillations and suggested deregulated GABA, glutamate circuitry that could, in part, relate to the cognitive dysfunction seen in schizophrenics? Do you believe a drug that might regulate this circuitry, like a glutamate modulator, might have some therapeutic utility for a subset of schizophrenic symptoms?
Well, glutamate is one of the most recently fashionable suggested chemical causes of schizophrenia, or some of its symptoms. And I haven't gone into the literature on glutamate in as much detail as I've gone into it with dopamine, but I'm not convinced that it will stand the test of time. What else is there to say about cognitive function and schizophrenia? It's very complicated. It's very complicated doing the research on it. People with chronic long-term schizophrenia or psychotic conditions do have cognitive problems. Some of that is probably the drug treatment, but there is probably an element of that's related to the condition as well. I don't think we currently know the biological basis of that, either the drug-induced element or the inherent element.
Okay, I have a second question. This time it's mine. And it's very simple. It's a one-sentence question. Do you believe there's an illness called depression?
No, is the quick answer. I don't think it's useful to think about what we understand as depression as an illness. When we talk about it as an illness, that conveys all sorts of ideas, that has all sorts of meanings attached, doesn't it? You know, that the problem is something in our bodies, something out of our control, something we're probably stuck with for life, something that we are going to need some sort of physical intervention to overcome. And I think those are all very unhelpful ways of viewing depression. And of course, when we're in an extreme mood state, you know, that's reflected physically, that exists physically as well as mentally. So there will be, you know, chemical events, physical events occurring when we're feeling depressed. That doesn't mean that they cause our depression. And I don't think we've got any evidence that that's the case, and I don't think it's a useful way to think about depression, because I think it's better for people to see it as something that they own, that they can potentially overcome. That's not to undermine its severity. Yeah, I think that'll do. Sorry.
Just one more thought about schizophrenia. John Nash. I mean, have we done MRIs on his brain to see if his repeated psychotic episodes affected the brain, you know, the gray matter of his brain? I would guess not. You know, in just thinking about the impact of the drugs. And I know that Peter Breggin did brain studies with rats many years ago and showed a loss of brain matter with the antipsychotic medication. So I would be highly skeptical of the theories around glutamate.
Thanks for your talk. I'll make an observation first and then a comment. We have, as you probably know, a pharmacy school on this campus. We also have a medical school on our other campus a few miles south of here. If I understand correctly, when one is considering the relationship between a particular identifiable disease and some proposed medication for the treatment thereof, use of a disease-centered model can only be appropriate if there's sufficient understanding of the underlying mechanism to justify that perspective. On the other hand, if we're not clear about what the mechanism is, then plainly, if any model could work, it would have to be something more akin to a drug-centered model. And that's not a trivial distinction, because in the first case, well, geez Louise, we have some sense, at least, of what's going on biologically, whereas in the latter case, we may not. And it's now back to my opening observation. It strikes me that that's a terribly important distinction that faculties of pharmacy schools and medical schools should be dedicated to drawing. And I'm hoping that faculties of both our schools are listening to you and considering how to respond.
Thank you. The thing is that if you gave someone a drug and it didn't seem to do anything else, but it made them better, then you could maybe assume or have at least some suspicion that it was having a disease-centered effect. And I think that's why, because the information about what these drugs are actually doing has been silenced effectively, I think that's why the conclusion can be drawn that they're having a disease-centered effect. So the argument goes, well, antidepressants help people with depression, therefore they must be acting in a disease-centered way, therefore depression must be a disease. But as soon as you realize that these drugs aren't inert, they make people feel different. People know that they're taking a drug rather than a placebo, overall anyway, if you take a group of people. Then you start to undermine that, because then there might be other ways that you could get the differences that you see. There could be other explanations for why they have effects. So I agree with you, but I think the other part of the picture is this silencing of the effects of drugs, and that's why it's been possible to conclude, even though we don't know what the disease-centered mechanism is, the disease mechanism is, that drugs have a disease-centered effect. So yes, nice point.
Thank you. I'm afraid this may not come through very clearly because it's still shaping up in my head. But I'm aware that from your discussion and presentation that drugs are an open question in many ways about how they help. There are things like a book called The Shallows, how technology is affecting our brain structure, and we're more sensitive to neuroplasticity. So if these other avenues to assisting people who signify they're in distress are only, what shall I say, marginal tools. They're all we have at the moment because we haven't sufficiently explored or found welcome in our society for other avenues of assistance. And my question to you is, you've opened up wonderfully portholes for other exploration. What are the ones that particularly intrigue you in this field?
So I think what you're asking about is what alternatives do we have? Instead of filling people full of drugs, what alternatives do we have? Is that? Yes, okay, thank you. Well, thinking about people with psychosis or schizophrenia, which is what I work in my day job as a psychiatrist, I'm enthusiastic about the Soteria project, if you've heard of that. That was Lauren Mosher is an American psychiatrist who set up a therapeutic community to try and treat people with psychosis, trying to avoid drug treatment if possible. There wasn't a blanket ban on it at all, but they managed to get about something under half of the people that were allocated to this therapeutic community through a psychotic episode without using antipsychotics, with reasonably good outcomes. And there's been a replication of something similar, but it's a community program in Finland. And there was another Soteria therapeutic community in Switzerland. And there's a network in the UK trying to set up small initiatives to help people to do that. And the other thing I'm enthusiastic, and the philosophy was very much about being supportive, non-intrusive, and understanding, and being with people while they were psychotic, really, and trying to help them to find ways to manage. I don't think that's possible for everyone. I do think there are some people who, become very deeply disturbed and become extremely inaccessible. Although I suppose the other point is that it's always important to keep trying, and as some of the antipsychiatrists argued, R.D. Laing particularly, there's a meaning in psychosis, however bizarre, however outlandish, however inaccessible it seems, and that it's helpful to try and find out what it's a response to. So that's one alternative, but. And for depression and other conditions, I think there are numerous ones. And just to say, I think this addresses your question a bit as well, which I don't feel I answered very well. In fact, I think the best answer to your question is depression and illness is to read Gary Greenberg's excellent book called Manufacturing Depression. But just also, I'll just take your question as an opportunity to say what sort of approach I think is sensible with something like depression. I think what's important is not to treat a label, and that's what I think is wrong with the idea of depression. You're then treating the label rather than the individual. And I think what's important is to find out what is this particular individual's problems, that this particular person who's in front of me, what are their problems? And as soon as you just use the label, you're not really looking at those, you're just looking at the label and the criteria. And so, of course, you know, the treatment of depression will vary according to the problems that each individual brings to you.
Anxiety can actually be some social condition. And if you stand allied with the person and exploring those issues, and if you believe in energies of various kinds being transmitted, which I do.
Yes, do I need that? You gave a teaser in terms of the sociological conditions that affect anxiety. And so I love the posture of the I'm the treater, you're the treatee, and here it is, disables us to explore issues that are big and affecting many people. If I meet with you and I say, I'm struggling with this feeling, you see, a lot of us today see this also. What do you think is causing it? You get into a whole different alliance, different energies, therapeutic energies are exchanged. And I mean...
really good point. And I think for me as a mental health practitioner, with that hat on, it's not really possible to be doing that because you are dealing with individuals. But that's why I think things like this, forums like this, are so important, because there is a political angle to this as well, as you say. You know, it's also important not to look at problems simply as problems located within an individual, to take a social perspective, to ask at a social level, why is it that so many people are still unhappy? What is it about modern life that makes people unhappy? We've got, you know, more material wealth than we've ever had in the history of mankind, and yet levels of discontent seem to be ever rising in surveys. And the answer is not in individuals' brains. The answer is in the sort of society that we live in.
But we do need some drugs. And for that, I really do want to acknowledge the good-hearted participation of my colleague, Gail Brazo, the Dean of the College of Pharmacy. And I think she did that. Thank you so much for attending and asking those questions. And I want to thank the audience for coming today. And I hope you keep coming to these events. They are very crucial to maintaining a sense of community and health. And it will help us avoid drugs in the future. Thank you.